I am pleased to introduce Dr. Ralph Sacco. Dr. Sacco is Chair of Neurology at the University of Miami and Chair of the AAN Academic Initiative. Dr. Sacco, I will hand it over to you.
Great, thank you. And thanks for helping us. The AAN, as you know, has been helping support the academic initiative. And this is really the third webinar that we have put forward to deal with helping our academic departments in dealing with COVID-19. And so I'm happy to help in any way, and I'll be introducing in a moment some of our panelists. So this is the third webinar we've given. We had the first one on April 4th, which dealt with some best practices, particularly among those departments that were getting ready for the surge. And we had a great panelist group discuss things about stroke, neurocritical care, neurohospitalists, and some telemedicine. The second webinar on April 17th, we heard directly from some New York City chairs about what was going on there, and then also some other chairs about some intra-departmental communication strategies. All of these are recorded, and they are available online at AAN.com and at the YouTube AAN channel. Next slide. I want to also put an advertisement in for our next one. We do have another one 2 weeks from now. And these two that we're putting on are all about reactivation. And today's is going to be more about reactivation on the clinical side. And on the 22nd, we're going to deal a lot more with on the education and training side. And it's a great panel that we have set up. So please mark your calendars. And we'll also have hearing from people from our undergraduate and graduate medical education committees. And it's opened up to a larger group for the one on May 22nd. Next slide. Also, I hope you all know by now about the AAN Resource Center. Like a lot of organizations, we've kind of consolidated all the information we have that's out there on COVID-19 resources, including things for our academic business administrators and our academic chairs. So please look on the AAN.com website where you can find a lot of things to help you in your departments. Next slide. So today's webinar's focus is more about, now that the surge is hopefully over and we're not going to see another surge, getting to reactivation phase, particularly on the clinical operations. So the topics we're going to cover are, first, ambulatory operations, getting neurology up and running again, the outpatient clinics, teleneurology, particularly virtual neurology. Is it here to stay? How do we integrate it with some of our in-person clinics? And then also some of the financial implications and also procedures. So, but all of it will be focused more on the clinical operations of neurology departments. Next slide. So we have a moderated panel. I have really great panelists I'm excited to be working with today. Larry Goldstein is here from the University of Kentucky. Matt Rizzo is here as department chair from the University of Nebraska Medical Center in Omaha. Kathy Sila is with us, department chair at University Hospitals Cleveland Medical Center. And then Larry Wexler in Philadelphia at Pennsylvania Hospital, chair there. And each of them have had different variations in how much surge occurred and where they are right now in the reactivation. So again, thanks to you all for being here as part of this, and don't let Matt confuse you. Matt Rizzo is really in Omaha, Nebraska, even though he has New York by now. We're going to start with some questions that actually had come in before in the past from the prior webinars, and many of these have dealt with, again, talking about reactivation, talking about the clinic, talking about how you're going to get your clinics up and going. So then we're going to start with Larry Goldstein at the University of Kentucky. How has your department, now begun to make this transition from the surge that you had, and you talked a little bit about what your surge was like, back to kind of some in-person ambulatory neurology clinics. Tell us a little bit about what you've done, Larry Goldstein.
Yeah, so we pivoted relatively quickly from a full in-person schedule to almost 100% telehealth, almost over a period of about a week and a half. That's the kind of change that we would normally take 6 months to a year to do, and we did it over a weekend to a week and a half. We still had some in-person visits. These were for patients who we first tried to do by telehealth, but couldn't do for one reason or another. We be in Kentucky, broadband is not available in large portions of our Commonwealth, so that's a problem, and some of our folks are a little technologically challenged. But having said that, we did move almost entirely to telehealth. So now
Larry, I didn't mean to interrupt. Did you keep any in-person visits going during even the peak surge for you?
We did, but we did it under very, very limited circumstances. What we did was we reduced the number of providers, neurologists, APPs, nurses, et cetera, in clinic at any one time. Our clinic is actually a fairly large space, so we could maintain fairly significant social distancing then. But again, only limiting it to folks who we urgently needed to see. The other thing is all of our neurodiagnostics that were non-emergent, they were all stopped. They were stopped not necessarily because we thought that there was a medical reason to. It was stopped because the governor barred any non-emergent procedures of any kind. So all of that, all of that stopped also.
We kept a few clinics for Botox, a few where people were just so afraid of either their migraines coming back or dystonia. So a couple of them were kept on an urgent basis, but you're right, did the same thing.
Yeah.
Let's turn first to Kathy. Kathy, in your outpatient clinics, Cleveland was hit. What did you do, and what are you doing now? We're kind of focusing on now, kind of post-surge. How are you beginning to make this transition?
Well, we're fortunate to have like 15 different ambulatory locations. 3 of our locations are actually in rural areas, and so we had pretty active teleneurology in those rural areas, and our telesleep program was already pretty established. And we had just done a grand rounds and had been doing some working with the faculty on, in your specialty, what could you see virtually? Because we were thinking of expanding some subspecialty clinics to these rural areas. So we've been working on this for a period of months, but within 4 days, it all went live.
Switched, yeah, exactly.
Yep, and this is it. You're getting paid now, so you thought about it. Okay, we're doing it now. And just like Larry, I mean, we were about 95% in office. We went to very little in office, and it was those things that we had talked about ahead of time that we didn't think we could do justice to in a virtual evaluation. But even those, we said, hey, listen, we'll see them virtually first.
Right.
We'll take all the history. We'll do the best we can. And then when we do have to come into the office for the detailed muscular examination or looking for tone or retinal abnormalities, that it would be a focused exam, maybe partnered with some testing that day so that, they wouldn't have too much exposure in the clinic space.
Great. And what about, Larry Wexler, I'm going to ask you about, we also did the same thing, but then we developed this bump list. Because when we first did it, we, if anything, first canceled or bumped them and developed, obviously, a list of new patients and followed be seen urgently for the quick switch to telemedicine. How have you handled, as these clinics have come back online, any of the bumped patients?
Like everybody, very quickly had to close down our clinics. And as a result, there were a lot of patients who were just called and told that the clinic was closed and please call it another time to reschedule. And so initially we had a lot of patients who were just pushed aside that now we're calling back and seeing if we could get them back get them back to visits. But as quite quickly, we got to the point where we were just calling and getting them scheduled for telemedicine visits, if at all possible. And the majority of patients, we could do that. In fact, we reached the point in the last couple of weeks where we were seeing as many patients total by telemedicine as we were seeing in person previously.
Amazing.
I mean, it's amazing that we were all able to do that. So we have a list of patients that we're now going back to, now that the clinics are going to open up, we're going to call them again and try to get them in to see whether now they are ready for telemedicine visits or they need to be seen in person.
So we're going to talk a little more about telemedicine in a minute. I want to focus a little bit on people that do have to come in person. As you said, Kathy and Larry, you both talked about exams that may have to be done. For example, our neuromuscular patients, they had a trouble with the virtual, and they felt, our pediatrics patients, they felt they needed some exams that were critical. So when these patients come in for exams and some that we need to do, what are you doing? And I'm going to turn to Matt a little bit. How are you dealing with, PPE and masking and even any kind of testing? Is there anything going on in Omaha that you're dealing with, Matt?
There's a lot of thinking about that. And, one of the even very essential things is, have you ever looked at those banks of how many people are affected and how many people are recovered? What does it even mean to say that somebody is recovered? You think about it, and it's really not clear exactly what that means. So our ID guys have come up with an operational definition of 10 days after you were identified as having COVID and 5 days fever-free. That means you're recovered, but it doesn't mean necessarily you're safe to run around. And that has impact on whether you'll see a patient and how you'll see a patient. It gets flagged in Epic. It remains for 28 days. And then they're treated or they're tested as much as possible by telehealth until it's safe to see them when they come in and they can be brought in for care. And safe means that, they're deemed not likely to be infectious anymore. That's after 28 days, and that there need to be appropriate PPE and protections and precautions.
Right.
That is both for the patient and for the providers. So, those conditions need to be satisfied before a person can come in after they test positive for COVID.
So there is a question in the audience that's come in and asking about if a person's coming in who is a known positive, what are the protocols that may be in place? And I guess if they're coming to a neurology clinic and they're already known positive for treating such patients. Obviously, there's the safety issues of your staff and what the patient is. But if somebody has to come in and they're known positive, actively positive, are there precautions you're doing? Let's go to Larry Goldstein on that one.
Yeah, well, thank the heavens, we haven't had to deal with this. What we would probably do is direct those patients not to our ambulatory clinic, right. Direct them to the ED. In the ED, we have COVID, a COVID restricted area and then a non-COVID area. So what we would probably do is direct that patient, if it were urgent or emergent, to the ED. Now, if it was just routine, we would delay.
Right. I mean, because you have to think of it, if somebody is actively positive and they're coming into your clinic, they're also contaminating, part of the facility. So we've done the same where you've tried to stratify in certain places where people would be seen. And there's even screening that occurs on your way into any ambulatory building. There's somebody at the front door that's asking questions. They're not taking temperatures yet at our place. But so yeah, Larry Wexler, you had your hand up. What about you?
I was going to say that what we're planning to do in our clinic is, first of all, everyone's treated as a PUI, as somebody who's possibly COVID positive. And so we're taking precautions on everybody. But if there's someone who we know has COVID and absolutely has to be seen, obviously we'd like to see them by telemedicine if we at all can. But if they have to come in, we're making sure they come in at the end of the day as the last patient, so that we can decontaminate the whole thing after they've been in the office. And that's if and when that has to happen, that's at least our plan.
And there are a number of questions dealing with procedures. We're going to touch on procedures shortly, but we'll get back to the procedures, both EEG, EMG, and maybe even Botox procedures in a moment. I wanted to stick for a minute, though, back to managing the in-person ambulatory clinic as it begins to reactivate, as you're starting to see more. Right now, we have a level where they say we should be at 50% in phase 1B that we're supposed to be in right now. So 50%, so our clinic is running, 2.5 days a week. But what comes up, in Florida and other places, our schools are closed. People are being schooled at home. Many of our staff and even faculty have young children. So I wanted to ask Matt a little bit about, at your place, what are you dealing to manage, the employees and or faculty when there are kids at home, getting them schooled and managing, shift work and being involved. If they have to come in person, or supporting you virtually? What are you doing to work around that?
I think that what we've been asked to do is to identify quote unquote essential personnel. So there are folks who just need to come in. Like, I'm an essential person, I have to come in no matter what. And so we have staff people who can do their work from home, and we try to accommodate them as much as possible. If they have to do their work in the hospital but they can't come in, there are other accommodations that can be made, like with flex scheduling, so that people can work the hours that they can work, maybe 4 10-hour shifts, a few hours here and a few hours there. There's an opportunity to take a couple weeks off with sort of COVID pay, which our institution has tried to cover with grants from the federal government. We have had instances where people could come in, but childcare wouldn't look at their kids because they had to prove that they were essential personnel. So we've had to write letters. The dean's office, I said, had to write letters on their behalf. There's an opportunity for people to take vacation. And, our goal is to preserve jobs and livelihoods and teams as long as we possibly can.
And we're going to deal with some of the financial implications. Each of us talked a little bit about what's going on, and there are some questions that have come in to talk about, from salary reductions to furloughs to reduction in staff. So we're going to get to that as part of the webinar. Sticking again to the clinic, a couple questions have come in. And again, we weren't focusing as much on education, but these are really important questions. All of us are involved with residency programs, medical students. Sometimes and often they're involved in the ambulatory and obviously your inpatient setting. Questions come in. What is your plan to reintroduce students into the clinics, wards, or telehealth visits? So who wants to try to tackle that? I know at our place, we've had to hold off for the in-person in the hospital. So all of our medical students have been put on pause for now. But what else in terms of ambulatory visits? How have residents and students been involved as you've begun to reactivate?
Students are basically verboten to come on campus.
Is that right? Yep.
And so they're not, it's a risk potentially to them and to the folks they encounter. And so they're just not allowed.
I think at our place too, for students.
They volunteered to help in other ways. And, they are, for example, helping to babysit for residents and staff who need to come in. There's a start date for them to come back, and for the M3s, it's the 28th of June, and for the M4s, I think July 5th or so.
What about in the ambulatory clinic? Sometimes residents are involved. I know in our hospital, our ambulatory care clinic is beginning to start up again, and there's in-person visits at a lower amount occurring. Larry Goldstein, how have you integrated residents at all in your ambulatory clinics?
Yeah, we resumed our resident continuity clinics pretty early on. And again, what we did is we used a combination of technologies to do that. The residents each got a HIPAA secure Zoom account. And then we also set up Skype for Business. So I have 6 residents each doing telehealth at the same time, just as if they were doing their clinics. And they would send me a Skype, I'm ready. And I'd say, okay, I'm with Dr. B, I'll be with you in a minute. And then we would first discuss the patient on Skype, and then I would Zoom into their room. We would see the patient together just as we normally would. And if there was nothing different than what we discussed beforehand, I'd say au revoir. And if not, I said, I'm going to talk to Dr. X, and he or she will then come back and speak with you again. And it worked just like a regular resident continuity clinic. It worked.
Our residents just gave a whole grand rounds today about how excited they are to get more engaged in telemedicine. So I think this is something we need to fully integrate and continue for the residency programs. There's a great question here, and it was one of the ones we were going to tackle, and this is something for Kathy. Obviously staff and faculty are sometimes at high risk, either their own individual circumstances or age alone. And there's a great question about, what about staff and faculty who are 65 and older? Have you had any protocols? How have you handled that, particularly as you moved into the reactivation phase? Kathy, do you want to start on that?
Yes, we identified some of our high-risk faculty and took them off the inpatient schedules if they were doing the stroke service or general or epilepsy service, and really put them in the ambulatory clinics to prioritize the telemedicine, which, you know, sort of gets to the other issue is that some of the other faculty are now doing a lot of weeks in the hospital. Which can be very stressful for them because that's, you know, that's a much higher intensity every weekend, that sort of thing too. So it's required some balancing. Most of the older faculty were actually very pleased, but one faculty said that it was discrimination and that he was healthier than some of the younger people and really was quite offended that he was taken off service. So it's funny the kind of different reactions that you get.
Anybody else on faculty at risk or older, any special circumstances that you've done?
Yeah, what we did, even early on when this was just beginning, I had several faculty that had medical issues that would put them at high risk. And we began doing telehealth for them down to our own clinics to begin with, so they wouldn't be down in the same areas as the patients were. But same thing, we also brought them off of any inpatient service, and some are younger, but they had medical conditions that would put them at higher risk, immunosuppression,
Right.
diabetes, hypertension, you know, the panoply of COVID risks.
So we've been talking a lot about telehealth. It kind of obviously connected in. It was sort of the saving grace for us during this change in terms of telehealth. So I'm going to turn a little bit now to some questions that have come in, as well as some questions that we had dealt with in the prior webinars that had been in advance and moved to a little bit more specific on telehealth. And the first one is really a little bit about you know, just the time has come to make this transition. And Larry Wexler, you were obviously, you know, one of the leaders in this, particularly when it was for stroke, and it was only being reimbursed in certain areas for stroke, and even at that, not easily. How have you handled that with virtual neurology? And then we're going to talk in a moment. Matt Rizzo is going to talk a little bit about some of the building, but why don't we start with you, Larry?
So, yeah, so first let me go back to the last question and say that I think 65 is way too young as a threshold. I think you ought to make it 70 at least.
Yep.
Yeah, no, the transition to telehealth has been nothing short of amazing. You know, we've been working for 10 or 15 years to break down all the barriers to the use of telemedicine, and all of that happened within about 2 weeks. And I think that you know, the response from the physicians has been terrific in terms of their taking hold of telemedicine and, you know, using it appropriately and using it effectively. You know, there's still a lot of work to do. It still could be a lot better. And I think that, you know, some of the things that we're going to learn from this whole episode is what are the strong parts about telemedicine? What are the weaknesses of telemedicine? How can we improve it? And how can we fit it into our armamentarium of things that we use to treat neurologic patients, even after we open up to, you know, get back to normal with inpatient visits? Because I think it's still clearly going to have a role and a much bigger role than it did before the COVID crisis. And I think we're going to know a lot more about it. And hopefully the technology is going to continue to improve. It's going to be a big part of what we do going forward.
The technology was great, and the learning curve moved fast, which was great in terms of implementation with electronic health records and with both faculty, and then obviously the patients also learning how to use it. The biggest thing, though, was also billing. Clearly, the fact that CMS kind of opened the floodgates for billing made a difference. So, you know, Matt, and there are a number of questions that have come in about the billing, particularly has your institution successfully submitted bills for telehealth with a variety of payers? Have you had issues with any co-pays? So Matt, I wanted you to talk a little bit about the issues regarding billing and reimbursement.
So I think it's already come up that this has developed very rapidly and successfully. And the bottom line, before sort of getting down in the weeds, is that CMS has agreed on, you know, reimbursing these televisits the same as an in-person visit. And that they've also agreed now to reimburse phone calls at the same rate as a CMS visit, which is wonderful. When you get down in the weeds, this is my slide for today.
Oh,
I don't know if you can see that, but
you can't see it, but that's okay.
it's an Excel spreadsheet of all the different kind of visits. You know, we have synchronous video visits that are bi-directional. We only do them by Zoom here. I know it's different at other places, but here we're not doing them by FaceTime or Skype, but I think they are being done that way in other places. And then for those, there are visit types like home call videos and COVID suspected videos and Medicare wellness videos. There are different use cases. There are different levels of required documentation. There are a whole host of CPT codes. Mostly we bill by time, I think. And then there are synchronous telephone visits, which are audio only, which are being reimbursed.
And right now they're being reimbursed at a pretty high level.
They're being reimbursed at a high level. The inquiring minds want to know how long this is going to keep.
That's the question, right?
Who knows what the future is going to be? We don't even know what's going to happen with COVID. But I want to say that it looks pretty good for video visits after COVID.
Yes.
I don't know what's going to happen with telephone. And then probably at your institutions like at ours, there are all kinds of cheat sheets that people get for how to make a phone call that's secure within perfect serve and so on. So right now the pay is good. It looks like it's going to keep up probably until at least the fall, but I don't know what's going to happen beyond that. It's a guessing game.
Yeah, I know that the AAN, we are advocating strongly to CMS, to the head of HHS to maintain this reimbursement, and that'll be important, including the audio only, because remember, the audio only is not only our fault, it's often the availability of technology and our patients, especially our older patients, to utilize some of the virtual services. So I think we're trying to provide that care as much as possible, and it has been helpful. I hope you others, I know Larry Wex will agree. Larry Goldstein, other comments about telehealth at your place? You said it kind of exploded. You think the billing is here to stay?
I think the genie is out of the bottle.
Yeah,
I don't think you can cram it back in. We'll see how CMS settles down once hopefully the dust settles.
Yeah.
But as I said, we have done surveys of patients and providers. The patients love it. The providers love it. If anything, their productivity is increased because, as Ralph, as I believe you mentioned, the no-show rate, has gone to close to nothing in the folks who we do arrange telehealth visits. Now, the problem is that we can't do telehealth in a significant number of patients for one technological reason or another.
That's right. So Kathy, let's go back for a minute. We talked about older faculty sometimes being, at risk, and older we'll define, depending on how we define it personally. But what about their acceptance of neurology?
The patients?
No, older faculty.
Oh, the older faculty. I think most older faculty who have had to learn all the electronic medical systems for documentation and doing all their billing, they sometimes come to this a little bit kicking and screaming because nobody likes change, or some people don't thrive on change. But certainly partnering someone with a younger, energetic, tech-savvy, wow, isn't this cool? I think that kind of mentorship is really important. And it's really enheartening for the younger faculty because they're actually teaching something to someone that they have a lot of respect for professionally. So I think it's been a real bonding experience for some individuals.
Yeah, it has. There are a couple questions that have come in, a little couple specific. One is saying that what platform are you using for the secure virtual connection? I know at our place we have Epic, UChart, and Zoom, but any platforms that you would have issue with or are obstacles regarding any of the platforms?
Yeah, let me take that one. We did not have a good specialty platform. It was more for the primary care, and it really didn't have enough licenses for all of the providers in specialty care to go on. So we were pretty much on our own, and we've developed about 6 different platforms. Wow. And this has now become the problem with integrating the central scheduling, is that they're not really sure which office is using what and what's the instructions, and we really need to move to a central platform soon so that it's not so cumbersome to do all the scheduling and patient education and that sort of thing.
Ours is all integrated. How about others? Larry Wexler, how is it working? What platform are you using to integrate in with your electronic health record system?
We started out with VidYO, video, and that we soon exceeded the capacity for that because it's a server-based platform and not cloud-based. And so we went to something called BlueJeans, which works much better and has lots of bells and whistles that are helpful. It has been integrated to some degree into our EMR through something that we have internally developed, which is terrific. It's called a virtual switchboard. And it's very nice. Your schedule comes up, and right next to each patient's name is a little button, and all you have to do is push the button, and you connect into a room where the patient gets a link ahead of time, and the patient links in, and right on your schedule is the link for each individual patient, and it also lists their phone number in case there's a problem. You could call them and say, you know, why haven't you connected? It's got all the information you need to. The idea is to make it as seamless as possible for the provider, so you don't spend 10 or 15 minutes up front on each visit trying to just get the thing going electronically.
Is anybody else on Epic? Larry Goldstein or Matt Rizzo?
Yeah, we're
on Epic, and it works beautifully. It's totally integrated in with the little Zoom button and a little video box you press in, and even the medical assistant can get in and Zoom with the patient before it starts. So are either of you on other kinds of platforms? Larry Goldstein, you first.
Yeah, we're just been doing all of our telehealth with HIPAA secure Zoom. We were actually forbidden to use any other platform.
Okay.
Our AEHR, though, doesn't directly integrate with it, but the scheduling does. So it shows up on the schedule as a telehealth visit. And then
somebody's writing in about Doximity, and I know Doximity has some. Well, Matt, what about you? What is integrating for virtual neurology at your place?
It's exactly what we're doing. We're doing exactly what you're doing, Ralph, which is Epic and Zoom, and it works like a charm. I want to say that we've also used video and BlueJeans, but that's been for other purposes in some research meetings that we've had. Zoom works so well, we use it everywhere now.
Yeah, well, it's working right now. Okay, here's a great question, and it still sticks with this issue, and it was one we were going to tackle. The transition or the preference, between an in-person visit that we all grew up on, we were all taught, and now a virtual visit. We know because of COVID-19, we went to virtual by necessity. But the question is, and we know the billing now is okay. Do you have a preference? And somebody's writing in saying that administration prefers patients to be seen in clinic rather than telemedicine because of reimbursement. That's not actually true right now, because it's actually the same. But then they say patients have valid concerns. Are you conflicted ethically asking patients to come in person when they're apprehensive? When especially we can do virtual neurology. I think most of us have already agreed that virtual neurology can be done and can be utilized. Do you all agree that that's reasonable? I don't feel like I'm getting pressure to bring them in person. Are you at your places?
No, I don't think we're getting pressured, but I think it is true that the distribution of the codes that are being billed virtually in the virtual visits are not going to be at quite the level of the coding by medical decision making and a complete examination that we might do in the clinic. So we've tried to do some waves of estimation of billing patterns of providers pre and post. And we think it's down somewhere between 10 and 20% just because of the codes they're selecting.
Really? Do you other agree with that? I thought the billing was almost at par, at least with CMS. But
So the
Larry?
billing is at par. I mean, there is parity of billing. So whatever you bill for, you will get paid the same as you do for the same code in person. The problem is that they're using the same system for determining payment for telemedicine and in person. So in order to bill a level 4 or level 5 new patient, you need to do a comprehensive examination. And that's difficult to do by telemedicine. Now you can go to time-based coding, and that's what most people are doing then to get around that problem. But then you're talking about 30, 45 minutes, 60 minutes of time. So that's the problem. Based upon the medical decision-making element and the comprehensive examination, you're probably by telemedicine limited to a level 3, and you really have to go to a time-based system. To get to your other issue about whether it's really okay to see these patients by telemedicine, should we push them in person? One of the things that we've done here is add a little legalese to each one of our visits through a little dot phrase that says that the provider feels that this visit can be done adequately by telemedicine without compromising the care of the patient, and that's part of every note that we generate by telehealth.
Since we're on the finance, here's a great one that just came in. Administration wants the facility fees, and they're concerned that if we move to all of this telemedicine, they're missing those facility fees, and whether private payers will match with CMS. So two-part question. One, the facility fees. Now, I've been told at our place that there's some other, through the CARES Act and other ways that they're going to make up for some of these facility fees. But any thoughts there in a point of service, I guess 22 versus 11 and facility fees in hospital-based clinics? Larry Goldstein, do you have any?
Yeah, we haven't gone there yet. We've just really been spending all of the effort trying to take care of the patients and maintain whatever revenues we can. We too, though, have done it completely time-based. It gets around many of those issues.
Anybody else with facility fees? Any thoughts there in hospital-based?
I think one of the big opportunities is not so much the patient visits, but it's the procedures. It's EEGs, EMGs, all the things that the hospital gets a tremendous amount of technical revenue for. Yep. And that's, I think, been a big hit.
Right. I know. Again. So, okay, we're going to be transitioning out of time, but last great question here, and we talked about this in the workup before the webinar started. New patients can be evaluated. We've all evaluated new patients. Yes, the exams are limited, but we've talked about, and the question comes in about less exam-dependent subspecialties, headache, epilepsy. My cognitive people are doing great. I think they're seeing more patients cognitive now than they did pre. So there are certain subspecialties that work as well. We recognize some don't work as well as others, but no, do you have any, I guess the question here is, are we doing new patients with telemedicine and virtual neurology? I think we would all agree that we are seeing some new patients, correct? Right.
Yes.
Okay. So we're going to pivot a little bit now off of telemedicine. It's here. We believe it's here to stay. The AAN will continue to advocate as much as possible to maintain payment for it. We had a number of questions. We're going to move now a little bit to Kathy's last point, moving to procedures. So I guess first, when we start thinking about procedures, what have we done in terms of opening up some of the procedures, EMG and EEG? And why don't we start with you, Larry Goldstein? How have you handled that?
Yeah, so as I mentioned before, the governor completely banned any elective procedures of any kind. So they were all completely shut down. Our EMU was shut down, et cetera, unless there was some emergency. So we're starting to redo these now. We're following the ACNS basic guidelines. If it's we do complete perimeter screening before the patient even comes through the door. When they come in, everybody is full masked and hand hygiene and all the rest. We were concerned about our EEG technicians and our EMG technicians, and even our neuropsychology technicians for that matter, who stay in close proximity to patients for an extended period of time. So we're having them use additional PPEs. We have the face shields for them. They can use N95 masks. We're not robing them and double gloving them or following that. And we're pretty much not bringing people in who are COVID positive or COVID suspect. Again, if it's an urgent thing, then we'll do those patients in the ED and in a separate area. But we're ramping that up now.
Yeah, we've started as well. So a great question you said. I mean, obviously, if they're COVID positive and known, yeah, we know what to do. Probably hold off on doing the tests. We know there are many people out there that are asymptomatic and could still be COVID positive. So a question for Matt in terms of dealing with any kind of prior testing or other procedures that you would either require, mandate, or have any protocols regarding testing before somebody is going to come in for an EMG or EEG. Any thoughts there?
Sure. If someone has had COVID, we wouldn't see them unless there was some emergency until 28 days had passed, sort of in line with what I said before. Then we sort of do the perimeter things that Larry mentioned. In folks who don't have any history of COVID, a clerk will call them 24 or 48 hours ahead of time and ask them questions like, where have they traveled? Have they had any sick contacts? Do they have any symptoms that fit with COVID? If they pass through that, then they get to the door. They get their temperature taken,
Yeah, they get the temperature taken. Yep.
Yeah, temperature masked, the operator is masked, and we follow usual precautions. So we will see those patients. We have seen them all along. And I want to say that the EMG business had been pretty good through April, actually. And now that we're opening up, actually, there are not a whole lot more of them coming, because even if the place is open and people have healthy concern, they may not come. So that's a whole nother side of this.
Right. Kathy, Larry, Wexler, other thoughts about any procedures and how you've handled it at your place?
So here I can tell you that what's happening is that anyone coming in for an elective surgical procedure is getting tested before they come in.
For an inpatient.
And they're generating a list of procedures that are considered elective surgical procedures. And we have asked to put EMG, EEG, and lumbar puncture on that list.
Interesting.
And so
they would get mandatory testing.
Correct.
Okay.
Yes.
And your testing turnaround times are fast enough that they could be seen, tested, and then you would know the result before your EMG or EEG?
Yes, we do it all. All the testing is done in-house here, and it's all 24-hour turnaround.
So that's a Philadelphia. Again, we know Philadelphia, probably among all of us, Philadelphia, Cleveland, Miami, or perhaps similar, but I think Philadelphia had the most of the surge.
No, we're doing something different. So we've got the screen clean and 6 feet in between strategy. But the COVID testing prior to procedures is limited to surgical procedures that require general anesthesia or other aerosol generating procedures.
Yes.
And right now, our pre-surgical positive testing rate is only 0.33%. And so no other procedures that are not associated with aerosolization are being put on that list. So that's really no neurodiagnostic procedures. And that has been somewhat of a conversation then about our PPE grid for neurodiagnostic procedures, EEG, that sort of thing, really looks at double masking and hand hygiene. And so we have had to negotiate face shields or goggles as an option for providers who want that additional protection to be able to smoothly ramp up the electrodiagnostic procedures.
So there's a good question that's come in. We've been focusing on the patient and obviously checking possible, testing on the patient. Some are doing more than others, it sounds like it. In Philadelphia, they're doing a lot of it, and others less of it. What about the providers who are conducting the procedures? And that was a great question. Are you considering testing your providers?
Yeah. So we
Larry?
we do the same perimeter screening that we do for patients. Every healthcare provider or staff or here goes through the same screening every single day. We do it on an app before we get here. We get here, I was screened and passed today. You get a little color-coded card for every day that you've passed the day's screening.
But you don't have to get tested.
Yeah.
Right? Okay. So we get
And
screened.
there's a good Stanford article that just came out about their employee testing that had a very, very low rate, and they used it as part of their marketing to make people feel safe to come to Stanford. Great article.
Our providers are healthy or something like that.
Yep.
Matt, anything in Omaha regarding testing of your providers?
So everybody who works here can be tested for free if they want to be tested.
Right.
And the governor has mandated that it be paid for, and HR has said that we will pay for it one way or another, but we're not testing everybody. Surgeons are all getting tested, every last one of them.
The surgeon. Oh, interesting.
Surgeons are getting tested.
So a couple rapid fire questions here. One, quick one. Has your EMU opened? If you have an EMU. Ours is opening up, yes.
Yeah.
Are sleep studies getting tested before they come in for a sleep study? No. Ours are not either. That was the no. And then somebody's asking about autonomic or what about autonomics, the Valsalva, or deep breathing portion of the test for those who do that kind of test?
Not the Valsalva part, but the rest of the autonomic.
Okay, great. So we want to pivot a little bit now in the remaining minutes to some of the questions that have come up. We wanted to make sure we on the finances. I mean, we all know that, anybody who's watched the television recognizes that we're in a global reduction in force in terms of people out of jobs, some of the highest record numbers, and it's affecting the healthcare industry as well. So we had a number of questions that have come in asking about what have been the financial ramifications that have occurred at your institution. Have there been salary cuts? Have there been furloughs? What's going on? So I think each of us want to tell a little bit about what's happening in our own institution. And maybe we'll start with you, Larry Goldstein, in terms of the financial ramifications so far.
Oh, it's been devastating. Most of the surgical volume for elective procedures all stopped. We have our clinic volumes have dropped, obviously dropped. The in-hospital volumes dropped dramatically, right? We're all asking, where do all the stroke patients go? Where do all the MIs go? Where do all the things that we normally take care of? When we're at 120% capacity 24/7, where do all those folks go? So the finances have been devastating. And our university is obviously closed down also. We're a component of a university. So the overall financial impact has really been quite.
What's happened in terms of the direct effect to your faculty or staff?
Yeah, so for the staff, some have been redeployed. There's been, every department had to do a 19.7% cost reduction based on furloughing. Faculty have given up vacation time. In the university overall has stopped, at least for the next year. The university matched the faculty retirement across the board. We had a 2-to-1 match between the university and the employee. They just went to 1-to-1, so it wasn't completely eliminated. There haven't been any salary reductions for faculty. But all of the usual bonuses have been either deferred or eliminated for the year. We had an
Yeah.
academic bonus, a productivity bonus, and those have all been put on deferred.
So at our place, the incentives obviously are in potential jeopardy. Merit increases are off the table right now. Also, any institutional contribution to retirement is gone, and that's going to be close to $100 million to the university in terms of, quote, a savings that's needed. I know Hopkins has done the same, and then we've had some reductions in leadership salary cuts at the moment, 10 to 15%. Matt, what about at your place? Anything? I think you were saying earlier that it's been okay so far, but
Well, you know, very much like what Larry mentioned, but we haven't had retirement affected. Incentives we will not be getting, merit increases likely not getting. The state budget is going through the floor. The university budget's going through the floor. So it's going to get worse, and the way salaries are handled is going to be restructured. So stay tuned.
yeah, there's probably more coming. Kathy, what about at your place?
Leadership, including chairs and division chiefs, took a 10 to 20% administrative cut. Our non-clinical administrative personnel took a 20% PTO work cut, but our faculty donated vacation days and made them whole. We haven't had any clinical cuts yet. Our matching funds from the hospital have been suspended for the year, and again, like others, no merit raises, no productivities, but no salary cuts yet.
Okay, well, that's good to hear. And in Philadelphia, Larry Wexler?
So like everybody, we've seen significant losses. It's a big system and there are big losses. But so far, they don't feel they have to make any dramatic changes. There will be no merit increases, but salaries we've been told the salaries will continue. The matching will continue. No furloughs, no layoffs, and no dramatic cuts in department budgets. So far so good. You know, it's still maybe too early to know what's going to happen in the next few months.
Yeah. Yeah, I mean, I think so. You can even see among our group here the heterogeneity, and I think there's likely a lot of differences. May also depend on the health of your healthcare system before COVID, how much COVID had an impact on your system, and you know, resilience, as well as state support and federal support. You know, some of the care dollars will help a little bit, but even, for example, we were just reading today in our own local paper that some of the care dollars were in Florida driven by CMS funding, and ours had less because of Medicare Advantage, while another place in Florida had more support. So there's a lot of variation there. What about strategies across the board here for kind of reassuring faculty and staff? I mean, every day we're dealing with concerns and about their jobs. I mean, any strategies that you'd like to share that you've taken on to kind of reassure your faculty and staff about the finances?
I think honesty is the best policy, is the best policy.
Yep. That's a great, yeah. I've been so transparent in our meetings, you know, and letting them know as soon as we know something. Others? Yeah, Kathy, I think you were going to say something.
Yes, I think transparency, it's very difficult to reassure people when it's really going to depend on the success of the reactivation and recovery policies to capture some of the lost revenue.
That's right. That's why the telemedicine and virtual, I think, is important, and filling it in. And, you know, I've also tell my faculty is sometimes, you know, it takes a little longer sometimes to do the virtual. So maybe they have to open up a couple sessions here and there. And we call these things where it's telemedicine on the fly, where you can get a couple visits in here and there. So we may have to find some other ways, particularly to bring in revenue. Larry Goldstein, what about you? I mean, you were great in terms of describing how you felt communication was so important in our other webinars that you've described, your interdepartmental communications, kind of keeping them up to date. Other strategies in terms of this concern about financial loss?
Yeah, well, I think, again, communicating often, articulating where we are, where we're going. You know, there's no way to sugarcoat this. It is what it is. I think being straightforward about it is really important. And also in terms of faculty morale, and our residents for that matter, is trying to keep business going as close to normal as we can. maintaining all of our educational conferences, maintaining all of the other things that we do. We've done things like health and wellness activities now through Zoom. We've had cooking classes on Zoom. So trying to maintain that connection, trying to maintain the sense of community, and being as transparent as we can with a real dose of reality. I mean, it is what it is. Here we are.
Right. Larry Wexler, I know there have been no cuts there, so maybe you haven't had to reassure anybody?
No, I mean, look, I think as everyone said, the key is being transparent and lots of communication, frequent communication, being in touch with everybody. In our department, we've formed a kind of a beefed up wellness committee that really helped bring a lot of concerns and making sure that everyone knows that we understand their concerns and here are the outlets for your concerns. And I think that's another helpful step.
Yeah, wellness has been critical, and we've shared, even if you have the personal stress that's going on, either from the finances or COVID-19, dealing with psychological support, virtual psychological support, wellness, even for our residents and faculty, the wellness has been critical to focus on. And there are virtual ways that can help. A question did come in here about how the plans to, quote, have faculty work harder when things get more normal. And I guess harder means taking on a little more clinical care than maybe they're used to, filling in for that long group of patients that are on the waiting list that had to be postponed, taking on some more telehealth visits. And they asked about Saturday clinics. Have there been ways at your place that you've taken on any, beyond the normal duty hours of clinics? Say, Matt, at your place, anything?
I think that census has been pretty low in the clinic, and we hope it'll get that busy, but I don't know that it will. And I think it's going to take time for people to come back. And I don't even know if people are going to be able to afford health care anymore, because they'll be out of work. So I think that would be a good problem to have. And I'm sure our people would be willing to pitch in if it happens that way.
Right. I think you're right. I think for us, it's the virtual neurology. Get people to do more of the virtual neurology as much as possible. That can be done. And we didn't touch on it, but all of us agreed. Our faculty do the virtual neurology from home. It's safer for them as well. And all of us have talked about that in advance, that they can do it from home as well. We've also talked about how to integrate in-person and virtual. Some people do in-person, and a virtual. Some people segregate, where they'll do some in-persons in a day and then virtual on another day. The virtual neurology, I think, will help us. And we're up to about 80% of what we were pre-COVID with the amount of virtual neurology, as long as we'll continue to get the reimbursement. So I think this has been great. I really appreciate all of the feedback and advice that each of you have given. It's clear that we're all dealing with different situations. I hope to the audience out there this is helpful. I know we couldn't get to every single question, but we will try and keep things going with other webinars in the future.